Hi, my name is Alexis Benton, and I'm going to be talking to you today about improving medication adherence, a journal club presentation. A clinical problem that we see a lot is medication adherence in patients, which causes us to see repeat patients or readmitted patients into the emergency department. This is a nursing problem because we see these repeat patients and it takes up rooms and staff away from our regular patient loads. Another nursing issue is we give the largest amount of teaching within the hospital or clinic. It can also impact the quality and safety of patients because it can contribute to their worsening health conditions if they're not taking their medications, which may make them need to take more medications on top of that. It's also changed their course of treatment and can cause another hospital admission. The number of patients impacted. 50% of patients don't take medication as prescribed. There are multiple articles that I read that state this fact, and this is the one that I happened to choose to cite on here. And it's medication adherence, who cares? And it was retrieved from the NCBI site. The nursing resources required for this clinical problem are extra nursing staff to accommodate the surge of repeat patients or readmitted patients on top of our regular patient load. There's also not enough monitoring equipment. If I can't put them into a room, we only have so much spare monitoring equipment to put in the hallway. And we also need more practitioners for this throughput to get these patients out of these rooms and disposed to either be discharged or admitted. Some of the cost issues that you also see are there's more fees for patients. So they need to pay a copay for the emergency department, for the doctor's visit, for whatever reason they're there for. It's also more money going into a staff, to equipment, and the maintenance of that equipment for this surge of repeat patients. The PACO question I have for the population, adult patients with primary hypertension, the intervention is pharmacist intervention in their medication management. The outcome would be to improve medication adherence over a period of 6 months, and the control group would have no pharmacist intervention whatsoever. The clinical problem my PACO question population are the same, except the PACO question is um, do adults with non-adherence to antihypertensives, whereas the clinical problem is adults with non-adherence to just medication in general. So this article is very specific to adult patients with primary hypertension who are taking at least one antihypertensive. The feasibility for implementing this intervention, currently in our practice, we only have a pharmacist there during the day shift. We don't want to have one there during the night shift. In order to do this, we would have to have pharmacy staff available 24/7. The article that I chose to use for this was a multifaceted pharmacist intervention to improve antihypertensive adherence, a cluster randomized controlled trial, or a HAPPY trial. And this was published in 2014 in the Journal of Clinical Pharmacy and Therapeutics. And the purpose of this study was to analyze the effects of having a pharmacist included in patient medication management. The sample size is 395. The sample characteristics are an average age of 66.7 years, and it's almost half male and female, but it leans more to male at 51.1%. And there was an unknown ethnicity. And the research setting was within 55 pharmacies across Western Australia, Tasmania, and Victoria. And in order to be included in this study, you had to be 18 years or older, so you had to be an adult. You had to be able to follow up at least 6 months later from your baseline. You had to have a diagnosis of primary hypertension by a general practitioner, and you had to be on at least one antihypertensive medication. The intervention type would be pharmacy medication management. So the pharmacist would be available during their discharge process in order to give that education to the patients about their medication. Um, in the actual article itself, this isn't in regular pharmacies, and the patient would need to go in at the beginning 3 months and at 6 months to get their blood pressure taken, and as well as have a short conversation with the pharmacist about making sure they're taking their medication, if they're taking it the most appropriate way, if they're getting it refilled on time, whereas the control group just got routine care. Order to measure this outcome, at every time the patient went and saw the pharmacist, so at baseline, the 3 month mark and the 6 month mark, the patient had a blood pressure reading, and there's usually 2 to 3 blood pressures taken in order to get an average. And there was a questionnaire about self adherence as well as a conversation with the pharmacist. A Chi-square test was used at baseline, and a t-test was used at the 3 and 6 month evaluation to see if there was a statistical difference between the intervention and the control groups. My study population, intervention, and outcome all matched the PICO question, and it was a complete match. A clustered randomization was used at the pharmacy level so that they didn't have any cross-contamination between the two groups. They wanted it this way so the pharmacy didn't have both a control group and an intervention group both going to that pharmacy, so the pharmacist could either focus on giving that education to the intervention group or not giving the education to the control group. There may be some cross-contamination if the pharmacist got confused and gave education to a control group participant. And attrition is a reduction or a dropout of participants. Originally, this study started off with 395 participants and went down to 354, 173 in the control group and 170 in the pharmacist group. A power analysis was done, and it was an 80% power with a two-sided p-value of 0.05. So that meant that there are 182 patients that were required to be in both the control group and the pharmacy group. External validity means that the study can be generalized for other study situations and is not specific to that one study. The one limitation that I saw for the population in this was that it was aimed for adults on antihypertensives, but this is a limitation because nowadays there's a lot of teenagers that are on antihypertensives that are due to poor diet and exercise. Even though this particular study was aimed at patient education within an actual pharmacy, I would want to propose a practice change within the actual hospital to include a pharmacist in medication management. And that means I would want them there for the discharge process, starting with admitted patients on the acute care floor, and have them there to answer any questions and provide intervention and education for these patients about each individual medication they will be taking. Some of the key administrative leaders I would need to speak to first are the chief of nursing, the pharmacy director, and the chief financial officer. This would trickle down to the unit directors, the charge nurses, and the on-staff pharmacists, and then eventually to the nurses, the regular pharmacy staff, and the doctors, the ones who are going to be on the front lines for this practice change. Two of the major cost factors in implementing this change would be hiring and staffing pharmacists so that they're there 24/7. There's only a pharmacist currently on our staff that's there during the daytime, so we would need one at night shift, and maybe possibly having two pharmacists together on day shift when most of the discharges are happening. And there would also be a charge to the patient for services that were rendered by the pharmacist. The best way to get this message across to administrative leaders and to any staff in general would be through a PowerPoint presentation with narration. You can show them a PowerPoint presentation all day with pictures, but they may not understand completely what you're trying to get across. And the key points that I would let the administrators know about is a decrease in repeat or readmitted patients. Um, this is a problem because we already have our um, regular amount of patients, and on top of that we have to find room and staffing for these repeat patients. This would decrease the need for the extra staffing on the floors. It would increase patient safety because we could have smaller patient assignments for these nurses. It would also increase patient safety because they would be adhering to these medications at home, which wouldn't cause a bigger health situation for them. This would also increase patient satisfaction because they feel like someone is actually taking the time to sit down with them and teach them about all these medications that they're supposed to be taking after discharge. Another benefit to having a pharmacist there 24/7 is if we needed a pharmacist in an emergency to mix medications at nighttime, they would be there. The reason I selected the acute care unit is because it has a slower rate of discharges compared to the emergency department. Their discharges happen in the morning and the afternoon, whereas the emergency department, their discharges are all day long. We would want to orient all acute care nurses on the day and night shift, the pharmacist, and the doctor so they know the process for discharging these patients. We want to start with staff meetings to get their opinion, get everyone on board, get any questions and concerns out of the way before we dive right into this project. I wouldn't want to include patients in this pilot, having them be informed, because I feel like that would create a bias and they may not listen to the pharmacist just knowing that they're going to be in the room. Rather, after that 3-month period, evaluate and ask these patients how they felt that the pharmacist was in the room educating them about these medications. I would want to look at the readmissions before this pilot process happened and calculate the monthly readmissions for 3 months. So 1 month, how many readmissions, 2 months, how many readmissions, and so on. In our current ER, if you look at who checks in, their name will be orange if any time in the last 30 days they were anywhere in the hospital whatsoever. So you could look at why they're being readmitted and was it because they didn't adhere to their medications. And at that point, you would be able to go to the patient, ask them why they didn't take their medications, if that's why they're being readmitted, and use a questionnaire that had typical patient responses such as the medication cost too much, or I wasn't able to get it, or I didn't want to get it, and compare these results from the pre-trial to post-trial. The biggest thing I would want to drive home for to maintain interest for the administrators is this is a big patient safety thing. If they're going home and they don't understand their medications, they don't understand how to take it, there's going to be a problem. It can cause them more health problems. It can cause them to have to take more medications for another readmission. Regular meetings and debriefing should be held for any questions or concerns that the staff may have. The expectation is with this pharmacist intervention and education is to increase the medication adherence and decrease repeat patients and any problems for these patients. And by doing this pilot on one unit, we can see if it works well for them and if we need to be able to tweak or change anything in the future for results for that particular unit. And then we can go on to implementing this change on all units, including the emergency department.